go into the system thinking that there's kind of this holistic way of being able to support people who are suffering, and you find out that there's this new movement around psychiatric drugs. So you said that you drank the Kool-Aid. Take me back to that younger version of yourself. And how did you drink it? How did it make sense to you? And how did you find it credible at the time?
Okay, I mean, this is hindsight is 2020. One thing that I picked up on already in medical school and in residency, when we were required to do rotations in other fields, just so that we had some medical training. So I spent a couple of months in the ER neurology, and the bias from the other specialties was like, "Oh yeah, you went into psychiatry because you're not good at believe that." And I wanted to know how the medications worked. I wanted to know the theories, the model. It wasn't just like, oh, I can't be a real doctor. And again, a lot of times medications are prescribed without the prescribers really knowing how they work. So I wanted to be really good at that. There were a couple seminal experiences, already in medical school. I remember being part of some sort of, it wasn't exactly a journal club, but I looked at the original SSRI studies, and they're not that selective if you look at them. And so, like, this whole term calling them SSRI, selective serotonin reuptake inhibitors, I was like, that's weird. And again, there was this big otherizing. Like in medical school, I did a rotation in an inpatient psych unit, and at the same time, I'd spend days or afternoons in an intensive outpatient program. And I remember this client revealing that they were also using substances, and it was like you could hear a pin drop in the room. It's like the psychiatrist was like, "Well, okay, let's send you off to a treatment program, and then when you're done with that, come back." It wasn't this holistic. It was like almost like someone said, "Oh, I have this STD," or something. It was bizarre. Like even within the otherizing, there was more otherizing, and that's sort of been this proclivity of mine is sort of seeing the shadow side of systems. In my college days was the heyday of postmodernism. Maybe that's sort of one of those gifts. But I thought, I don't want to just be a psychiatrist because I'm not good enough to be another doctor. I really want to be well trained. But the cracks started appearing in the system. I remember one client, we do these rotations. I'd rotated away from an outpatient clinic, and this client I'd seen in this previous rotation was sitting in the waiting room, and I'm like, "Hey, how's it going?" And he's like, "Terrible. I'm still feeling something." He was drooling on himself, horrible medication side effects. But this whole idea he'd been programmed to accept is if you feel something, we got to change our ad medications. And another conversation around that time, I was like thinking, how can people that are in what's called the continuing care clinic, which again is an ideology, how can they have more meaningful lives? Graduate or so that they're not these professional patients. And this one supervisor said, "Well, every place I've ever worked at has had a continuing care clinic." And I was thinking that's exactly the problem. So I'm sort of getting ahead of myself, but I think the other thing sort of cracks appearing was, there was this big push for evidence-based medicine, which again is an interesting ideology. It is really the pharmaceutical industry saying, well, we can do these studies, and anything else, we have an ideological sledgehammer against. And the bizarre thing was, so when we'd have these supervisors in training, the clients obviously had been in treatment for a while, and they'd gone through a lot of the evidence-based, as thin as that is, algorithms, so, first line, second line. And then these wise old people of psychiatry, mostly men, would be like, "Well, my secret formula is, this and this." And while it was nice that they had clinical experience, they completely undermined their entire ethos of, "Oh, we got to be evidence-based. But if that doesn't work, I've got my secret formula." Cracks started appearing. One thing that I did was, having attended or done residency in psychiatry in Albuquerque, New Mexico, at the University of New Mexico, there was this program, it might still exist, called the Program in Rural Psychiatry, and I was interested in that. And through that found out about a treatment center in Gallup, New Mexico, to help very impoverished, very severe substance abusers, mostly alcohol, mostly Navajo or Dene tribe. And this center had really just got, the citizens of Gallup marched on foot to Santa Fe, which is like over 200 miles away, to say something's got to be done. And the center was set up and really underfunded. And what the treatment really was Navajo tradition, was, reacquainting people with their traditions. And I went there, I helped out in different ways, but I never wrote a single prescription. Once I took a friend of mine from New York there who was working at a substance abuse treatment program, and he's like, "Oh, this is your non-prescribing rotation." And that was, again, that's that seed that got planted. Like, there's so much more beyond prescribing. The other thing, again, maybe I'm getting ahead of myself, but I like history, and when we learn about Eugene Bleuler and Egon Kreplin in medical school or a psychiatry class, or psychology class undergrad, it's like, well, Bleuler called it schizophrenia and had the 4 A's, and Kreplin called it dementia precox and felt it was a biological illness. And so, it's a biological illness, so we honor Kreplin and we honor Bleuler by taking his name for it. But that's actually, again, an ideological oversimplification. What really happened was Bleuler, the 4 A's are really all symptoms of interpersonal deficiency. He used the term autism, not in the modern diagnostic sense, but difficulty communicating. I admit I can't recall the other 3 A's right now, but it was all about difficulties interacting, difficulties being in the world. And Kreplin said, oh, it's a biological illness. So the entire ideology, that debate about war is the locus of illness, what makes these people suffer, in a subtle, and again, there is no alternative way. We live in an article I read many years ago called "We live in a neo-Kreplian world." If the locus of illness is other people, like you've alluded to, then what, with the children, then giving a medication isn't treating the illness. But if we say, oh, this is a biological illness, which is an ideological choice, then we have a supposed philosophical underpinning for why medications are the answer. So that we've sort of swallowed this. Behavioral health has swallowed this ideology without really knowing where it came from or questioning it. And it's not the truth. It's just one guy's idea 130 years ago.
Yeah, it's interesting because I'll just refer to a couple of clients that come to my mind yesterday. So this idea of evidence-based medicine is one that can be very manipulated and distorted. So an example would be this. Sean, maybe you're having difficulty sleeping.
I am.
Okay. And you drink a 12-pack on a Saturday night of beer. And then you pass out and you get 9 hours of quote unquote sleep. Right. Does that make Miller Lite then an evidence-based treatment for insomnia?
I guess who's running the study? Is it Miller Lite?
Exactly. And it's the same thing like when a client says, well, I've been having trouble with sleep and my doc prescribed me trazodone and Seroquel and Klonopin. And I was able to sleep. I was like, well, yeah, that knocked you out, didn't it? And that's going to last for maybe a while. It's certainly not going to provide restorative sleep. So how you feel when you wake up in the next morning? Well, a little bit drowsy, but I was able to sleep the night before. Right. And so we can communicate that as evidence-based medicine, but it's sedation. And drugs sedate people, alcohol sedates people. And we use the term medicine. That's why I hate using the word psychiatric medicine with the idea that it's somehow medicinal, right? A plant could be medicinal. Certain food can be medicinal. I certainly understand how the idea that we can ingest something that can be corrective, that can be healthy for us, that can be restorative, but drugs are not that. They are synthetic chemicals. They're created in a factory, and they induce a biological reaction or response, whether that's hormonal birth control or whether that is trazodone or Seroquel or selective serotonin reuptake inhibitor. So that's part of the mass manipulation. Two things here. One, that the reduction of an emotion is a positive outcome that leads to long-term health. Okay, that's the lie. So trying to reduce the intensity of an emotional state can be communicated as, at least in the short term, an evidence-based treatment. So all you have to do is create an outcome measure that reflects those physiological symptoms. So same thing with anxiety. Sean, let's say you were really, really anxious and then you drank that 12-pack and you were not so anxious anymore. Then is Miller Lite a evidence-based treatment for anxiety because it led to the reduction of anxiety?
It is anxiety reducing.
right? And that's somehow, despite centuries of knowledge, as well as our own experiences being human beings, and then a lot of the evidence base that I was exposed to in the psychology field was the allowance and experience of emotions is therapeutic, right? It's a learning component. It's a necessary biological response or even a spiritual response that provides us like these distinct messages. There would be exposure-based treatments. I mean, this was always the mind for me. You know, I'd go into my graduate school programs and I'd be working with people who have phobias or obsessive compulsive disorders, legitimate fear-based conditions that are leading to avoidance. And we are systematically exposing them to that fear to create new learning. And then the reduction of fear is included over time through systematic exposure to what they're afraid of. And the way that you maximize these treatments and exposure-based therapy is full exposure, right? Allowing the emotion fully to experience. And you realize that you start targeting the fear of fear, that people have a fear of their emotional states. And once they give up the fear of their emotional states and they allow themselves to embrace the situation that they were afraid of, they learn. It's like an adaptive mechanism. So if I learn that Sean is a scary, violent man somehow, and then I stay away from him, I never correct that learning, but I have enough experience with Sean, then it changes my viewpoint and it changes my emotional experience. So these very adaptive experience. And then you go into psychiatry and they give you the exact opposite. Oh, you feel too much. That's a symptom of a condition. Let me drug you till you don't feel that again. And so it never made sense to me, Doc. When I was a 22-year-old man, it didn't make sense to me. And I was always open to I could be missing something. Maybe there's these real serious mental health conditions. I didn't really understand what bipolar disorder was at 22. I don't think I understood schizophrenia at 22. So I was open to the idea that there could be some role in medicine improving the quality of life from people who were really disconnected from reality. However, the more you dig, the more you learn. None of that really plays out. And the labels that we were using to identify them as diseases are not accurate. They are kind of crude labels that don't actually reflect the real conditions.
Well, you said so many things, Roger, and please call me Florian. I'm just going to try and remember some of what you triggered in me. First of all, you know, the word pharmacology comes from the Greek word pharmakon, which means the poison. And, you know, Paracelsus said everything's a poison. It's just a matter of the dose. And in fact, the basis of pharmacology is always to interfere with the natural function. You know, the SSRIs block the reuptake inhibitor, etc. Now, where I'm going with this is there's the word pharmakos in ancient Greek, and that's the scapegoat. And, you know, there's a long tradition of, you know, they say, okay, you know, our community, we've had drought, we're no food. You, Joe, you got to go. We're either going to sacrifice you or we're going to exile you. So there's this weird parallel to me at the root of the word pharmakon and pharmakos. That's one thing. The other thing is, again, talking about the hidden ideologies. You know, I listened to a brilliant talk a couple of years ago, and I don't remember the name. It was a behavioral economist, and he said, you know, capitalism is making us sick. And so, and then another talk I listened to recently where when things are wrong in the system, you know, jobs, work, capitalism, whatever you want to call it, lack of meaning in life, lack of connectedness, instead of saying, well, we got to change the system. No, it's your fault because you're not fitting into the system. You know, so there's this big ideological, in order to be a functioning member of society, you have to meet these criteria, and that dark night of the soul feelings, even insomnia, well, they don't fit that. I mean, the idea that we need to sleep, 8 hours at night continuously is a modern invention based on capitalism. Okay, if I want you working in the factory from sunrise till sunset, you better get your sleep at night. And, you know, the human body is perfectly capable of missing sleep, but we've created this, oh, it's my fault, it's something wrong with me. You know, if you just say, oh, you know, I'm having a sleepless night, well, let me just embrace it and look at everything else. But again, it's been this weird upside down. Something is wrong with the way we live our lives. A lot of people are struggling with meaning. Well, there's a pill for that. It's bizarre. And then the pills don't really, I mean, the withdrawal syndrome, and I don't want to get ahead of myself, is a feature, not a bug. And no one teaches you how to get people off medications. And, medications pile on, and then I'm still feeling something. And again, locus of illness. I had several clients over the years with psychosis say, don't take away my voices. They're my only friends. They are so lonely. They're so isolated in society. And in fact, the medications we give that cause tardive dyskinesia and a lot of the other symptoms that make people, oh, that guy's crazy. Well, that twitching isn't psychosis. That twitching is a side effect of the medication. So we're actually contributing to the stigmatization, isolation, this othering through the very act we do. And it was much more curious about your questions than what I'm going to say. But when I was after residency, they hired me and I became part of the Department of Psychiatry for a few years. And I was involved in the residency matching process. We select the new crop of medical students. And many people would say, oh, the reason I want to become a psychiatrist is because in college I got depressed and I took an antidepressant and it was great. And as if saying, well, this person obviously had great personal connections. Like, well, they got depressed before. Are they going to be able to handle the stresses of residency? I'm not sure we want them. It's like there's this hidden knowledge that what we're doing isn't working. All it does is people get identified or self-identify as somehow deficient. Including and the other thing I'll say is there's no such thing as a side effect. That's a pure projection. Benadryl, if you have allergies, the fact that it makes you drowsy is a side effect. If you're using Benadryl for sleep, the fact that it dries you up and dries up your mucous membrane is a side effect. Well, which is it? You mentioned, well, maybe I'd heard you or imagined things, but Seroquel quetiapine was never approved for sleep, and it's massively being prescribed and sold for sleep. And then there's this whole other thing. Oh, there's good medications and bad medications. When I was in residency, even though I never prescribed an opiate, I remember the drug reps, like there was that TV series with Michael Keaton recently, I can't remember the name, but the drug reps were coming in saying, well, do you know you could get sued if you don't prescribe, if you don't relieve your patient's pain enough? Really manipulating us, just like in that miniseries. So there's all this manipulation happening. You have to prescribe. This is on all these levels. And again, with the medications, the data is really, well, and then, there's this effect, the filing cabinet effect. If you say, oh, I'm evidence-based, I only look at the studies. Yeah, but you're not looking at the 90% of studies that are in the filing cabinet. Yeah. So even saying I'm evidence-based, you've already drank the ideological Kool-Aid.
Yeah, not only that, I don't even know if they're very good at deconstructing the methodology and the statistics. So, it's very clear that the conclusions of a lot of these studies don't actually meet the data. And that's why it's so nefarious, because you're talking about ghostwriters who are funded by these pharmaceutical companies who are pushing the drug out to market. A great example is Lexapro right now, that was approved for children as young as 7. It's very clear that it did not outperform a placebo. And when you have a 6-fold increase in the likelihood of suicide, when you give that drug to a child or a teen compared to a placebo, how does something like that get approved? And how is that something that is actual part of a clinical guideline? The docs don't know this because they've never read the study. What they'll do is they'll read the conclusions, which are something ridiculous, that they believe it's safe, it's tolerable, and it can be effective. And how is it based? How is it effective? There's 5 outcome measures. 4 out of the 5 outcome measures, it doesn't even outperform a placebo. But one outcome measure that they construct themselves, they can find a statistical difference and then use that. If a doctor doesn't know the difference between a statistical difference between a drug and a placebo group versus clinical relevance, if they have no idea what the outcome measures were, if they don't know that it increased suicidality 6-fold, then how do you provide informed consent? So it's an illusion of evidence-based medicine that is based on marketing propaganda, because most of the doctors today do not have the time to read any research. Their research is what the drug rep tells them or what a guideline tells them. The guideline developed by these major medical organizations funded by the pharmaceutical companies themselves. It's a game that we need to be able to know the rules in order for us to be able to keep ourselves safe. And that's why we need more honorable and conscious clinicians to be able to have to understand what this literature is, to communicate it to people, to make informed consent. Now, I want to get an idea about how your colleagues are viewing your profession. So going back to when you were in the system, when it was the revolution of biological psychiatry and that there are medicines to target brain conditions. What was your experience with your colleagues? My experience in the field is I wasn't seeing people get better, and that's how I needed to wake up
Yeah.
and see how I could help people. I don't know how people are doing the work under this delusion that they see improvement from their clients.
Yeah. Well, I think that's where it starts. How do we define improvement? I think you alluded to it. The measures we have are biased towards what we want people to function like or behave like, and what the drugs can do that we can measure. And that's really problematic. The years ago, there's this whole debate about self-medication. When people use illicit substances, are they self-medicating? Well, the self-medicating, the criteria used was what, let's say, psychiatrists were saying, well, this is what I think you are trying to self-medicate. No, why don't you ask the client, again, even the word, why don't you ask the individual, how does this work for them? Why does someone with psychosis use methamphetamine that worsens psychosis? Well, what's their behavioral economy? What are the choices they're making? But I want to go back to your question. I mean, I think there was, again, so many people I met said, well, I'm a biological psychiatrist. And that was like pretending, it's like putting the blinders on and saying, well, if I pretend that all the interpersonal factors, all the unconscious transference, countertransference, we have all these fancy labels for it. If I decide that doesn't exist because I'm a biological psychiatrist, I don't have to think about it. And one of the greatest psychiatrists in America was Henry Stack Sullivan 100 years ago, and he wrote a book called The Psychiatric Interview, where he says it starts the moment you first lay eyes on the patient. And I would argue it actually starts long before, because the entire system, what makes people say, something is wrong with me, I got to go see someone. I had this experience years ago on an inpatient. I was running an inpatient unit, and one of the patients, again, both these words don't work for me anymore, was wearing a T-shirt, "People like you are the reason I'm on medication." And the entire unit had a meltdown, the other clients, the staff, because it was true on so many levels. So there was this holier than thou, well, I only look at the evidence. I don't eat the food that the drug companies bring, which, is a practice that, as far as I understand, has disappeared. And I had someone tell me recently, you know what, I love psychiatry. And I thought about it. I don't love psychiatry. Even if you're like, well, I only look at the studies and I don't eat the food that the drug rep used to bring, you are still in the ideology. You've still drank the Kool-Aid. And I don't want to sound like I'm so much better or more enlightened. For me, I realized in the last few years how, well, it's a longer journey, but how much this identity has taken up root in me at such a deep level. And on some level, I mentioned sort of the subtle pressure to go into medical school, but even with the psychiatry, I think it was an identity I was hiding behind. And I'm just sort of discovering, like, who am I really? And that's maybe outside the discussion about the ideology, but I think the ideology is very seductive, and maybe there's a better word, but like, oh, we're the tough guys. We deal with the conditions that no one else wants to deal with. When there's another medical specialty and there's the specter of a psychiatric condition. As I said, let's turf them off, psychiatry, even that word turf, and then we'll roll up our sleeves and we'll do the dirty work that no one else is willing to do. So that's part of the ideology, was that, oh, we do what no one else does. Part of the ideology was, oh, I only look at the study, so somehow I'm better or more informed, when the entire field, even the way illnesses are constructed, it's like, years ago there was a review, I want to say it was in the Atlantic. It was a book review of the DSM-5 as a dystopian novel. There's no way out. There's no definition of healthy. If I ask you, how do I get to LA from here? And you say, well, don't go this way, don't go that way, don't go that way. I still don't know how to get there. There's no definition of health and of what it means to make the most of living our life. Instead, you're really stimulating me. It's like, shut up and take your pills. And that